Uday, go ahead and start.
All right, awesome, cool. Welcome to Jeopardy. 2 more hours left. I know the last thing you guys wanted to do was spend the last 2 hours of the lecture year hearing me talk, but this one will go quick. I think what I'll do is, for time's sake, because I really want to get to the next lecture, which I'm more excited about. Um, instead of doing all 6 sections, we'll just do 4 sections. And so for today's Jeopardy, the categories. Well, welcome to Jeopardy, Critical Care Jeopardy. Um, I can never know if you guys can actually hear the sound effects, but the categories for today, it's all about mastering the waveforms, a big part of our daily practice, something I don't think we get enough attention to. So one is feel the pulse, basically arterial and PA catheter waveforms. Next is vibing vent, and so really try to name the mode of the ventilator based on the waveform. We'll have sync or sync, so a lot about ventilator asynchrony, which hopefully by now is review for you guys since we've had a few lectures on this. And then finally, we'll do pump it up, which is waveforms in routine MCS. The ones that we'll skip today will be POCUS is everything, because I think we've had enough POCUS, and then first look, which is more about just everything about basic patient monitoring, the initial screen. So with that said, I can't see you guys. So maybe what we can do is whoever says their name first can just kind of answer. We can go from there. I don't think we're keeping points. It worked out pretty well last time. And then whoever gets the answer right can go ahead and pick the next question. So whoever wants to go ahead, please do. So once again, just the first 4 categories.
Let's do sync or sync for 100.
Sync or sync for 100. Once again, that is ventilator asynchronies. So what are 3 potential causes of the ventilator pathology in this image? So, obviously the first part is identifying what the pathology is, which is amongst the asynchronies, one of the easier ones, I think.
Autopeep? Yeah, that's what I was saying.
Sorry?
Autopeep?
Yeah, so now what are 3 potential causes of autopeep? Let's go with that. And if you can even name 2, we'll go ahead and count that.
You mean like disease processes? Is that what you're asking?
Yep.
Like asthma?
Yep, that's one.
Iatrogenic if the rate is too fast?
Right on, right? So perfect, right? So right on, man. So, you can be asthma, COPD exacerbation, basically really bad bronchospasm, or it could be iatrogenic, right? You could set the rate too high, the volume could be too high that in that short amount of time, you're not able to get that adequate volume or expire that adequate volume. And then obviously if your I time is way higher than your E time and therefore causing autopeep or gas trapping. Oops. So, a few things. So, we talked about auto peep, or, better known as intrinsic peep. It's when air becomes trapped in the lungs due to basically you not being able to exhale enough. And so asthma, COPD, anything that could cause narrowed airways or increased air resistance. And like you said, right, high respiratory rate, high tidal volumes can also cause it because you're not allowing sufficient time for full exhalation. And the problem with all that is that it'll lead to increased work of breathing, hemodynamic instability, and barotrauma. So what you're looking for on the waveforms is that you'll see that flow time curve. It doesn't return to baseline before the next breath begins, indicating trapped air. Now, keep in mind that that is not, in my opinion, and I'm sure everyone else can kind of chime in on this, the best way to identify this, because sometimes the rate is so fast, especially if they've already crossed that curve of being unstable from a respiratory standpoint where their work of breathing is increased, you may not see it, right? And so what you can also look is on the pressure time curves. This is when it kind of passes that curve because everything exists on a spectrum. You start to see that the baseline pressure starts to increase before the start of the next inspiration. And so, to kind of manually measure the auto peep, you can perform an expiratory pause maneuver. And that involves temporarily stopping the ventilator at the end of expiration and measuring the pressure, which should reveal the amount of trapped air inside the lungs. And then, obviously you want to fix this. And so a couple ways you can fix this. You can do the opposite, right? You can decrease the respiratory rate. That's the one I found to be most effective. You can reduce the tidal volume, or you can increase the expiratory time by adjusting the the I to E ratio. And that should allow for complete exhalation and thereby reducing air trapping. One of the more complicated maneuvers that I'm sure we've gone over in the past is basically increasing the PEEP provided you have good evidence to do this, and that allows you to overcome the intrinsic peak to allow that air to be exhaled. Solid job, man. Sanjay?
Let's do feel the pulse 100.
Feel the pulse 100. I don't know why, but usually they gray out the ones that we've already done. So if someone can just help me keep track of the ones we've done. Feel the pulse for 100. All right. A pathology indicated by the absence of this notch.
Indicated by the absence of this.
So, what is, I think first step is just identifying what waveform we're looking at. Can anyone just tell me what waveform we're looking at?
PA catheter, would that be pulmonary, like regurg, if it was absent?
Dude, you are on fire, man. So, right, exactly, right? So you're looking at a PA catheter, and where specifically is that PA catheter right now in that green circle?
It's in the pulm valve because of the diastolic step up.
Yeah, absolutely, man, right? So you are looking at basically in the PA, and the answer is basically it could be pulmonary valve regurgitation or just incompetence. It could be malpositioning or it could be dampening, which we'll kind of touch on more, right? So what you are seeing is that dichrotic notch, and it's that small distinct dip seen in both the arterial and pulmonary arterial waveforms. And really the waveforms are pretty similar when you just kind of break it down, right? What's happening there, it's in the arterial valve, in the arterial line, it's indicating the closure of the aortic valve. And then in the PA catheter, it's indicating the closure of the pulmonary valve. So now if that notch is not there, it could really mean you could have pulmonic regurg where the valve's it's failing to close. And so you don't see that pressure change from when the valve closes. And obviously the other thing to think about is that it could be from catheter malpositioning or dampening due to things like air bubbles or clots. And that really just interferes with accurate pressure of the accurate transmission of the pressures, causing that notch to disappear. Just something to keep in mind. Solid job, man. These are just some more examples of what would cause the notch to appear abnormal. So you can also see with a calcified aortic valve, and then you guys probably won't see many congenital stenosis aortic valves. This is more for arterial line waveforms. Oops. All right, cool. So we did do sync or swing. No, we did sync or sync for 100.
Could we do feel the pulse 200?
Feel the pulse for 200. All right. This could be indicated by the following arterial line waveform in a patient that is passively ventilated.
Passively? I guess this is stroke volume variation, but that would be with if they're paralyzed. Which would be an indication of hypovolemia, but passively ventilated.
And anyone can answer. Just say your name.
I have no idea.
I assume the question is trying to get at the pulse pressure variation, right?
Yeah, and so what could that mean in a patient that's passively ventilated?
It could be hypovolemia, but in a passively ventilated.
It's not true.
It's not true. Yeah.
Like passively ventilated versus actively ventilated, it doesn't matter.
Oh, so hypovolemia?
Yep, right on, man. So, yeah. So after right? So
It's not the thing that if you increase the PEEP in a ventilated patient, you're just going to decrease preload. So if you're still seeing actively with a decreased preload, it would mean a real hypo.
Yeah, just more obvious.
Yeah. And so the reason why I throw in the passive ventilation is because that's how initially when we identified this, a lot of the studies were done. But you guys are absolutely right if that's what I'm hearing. Is that you can do it in patients that are not fully passively ventilated, but you have to be on a certain amount of positive pressure. And so, it all depends on the studies that you look at and then also what you see in a clinical scenario. It's important to be aware of when you would see pulse pressure variation and they're not fluid responsive, but there's another more obvious reasons for why you would have pulse pressure variation. So that's obviously the equation. That's more for your boards. They may ask, the 12.5 or 12% or 13%. If you actually do the math, how much more than that you should be to indicate fluid responsiveness. And so really what's happening physiologically, which will kind of lead you to the other differentials, is that you're seeing changes in intrathoracic pressure, right? So when you inspire, you'll decrease venous return, you'll decrease the stroke volume, and that'll lower your pulse pressure. And the opposite will occur when you're expirating. And so, the other causes of what could cause this pulse pressure variation to this severity would be obviously hypovolemia, but you could have right ventricular dysfunction, you could have cardiac tamponade, and you could just have notable increase in work of breathing. So if you're breathing like a lot of our critically ill patients, they may not be volume responsive. It's just that their inspiration and expiration is causing such dramatic hemodynamic shifts that you're seeing this pulse pressure variation. So ideally, when you're making that call to give fluid boluses because of an arterial line, you want the patient to have a regular rhythm and you want them to be in controlled ventilation settings, whether you're doing it on non-invasive or on the vent. Oops, let me go back to that. And so this is kind of the diagram, just kind of showing how the stroke volume would change. And then, I like this mnemonic a lot of reasons to have, false positives, false negatives. So, if your heart rate's too low, or if you have irregular heartbeats, your tidal volume isn't high enough, if you have increased intra-abdominal pressure, if you have an open thorax, such as, having a chest tube in place, or if you're spontaneously breathing, it could go either direction.
Could you do first look for 100?
Oh, so let's skip that section. Let's skip the last two sections.
Oh, sorry. Pump it up then at 100.
Pump it up for 100.
It's gonna be bad.
All right. This is what is occurring in a normal balloon pump waveform, and specifically where that green arrow and green circle is. It's pointing at the same thing. And I know you guys have Jared right next to you, so if he's hinting answers at you, then well done.
He's hanging us out to dry. So.
That's my man.
Aortic valve closure. It's not. Boo.
You're close.
Aortic valve opening.
So I'll give you a clue, right? It's what is happening here because the balloon pump is in place. And that's, you're confirming that it is happening based on that second peak that you would not see in a normal patient.
So what's in the normal patient? What's in that patient that's not in the normal patient?
Meaning the pump.
Like the pump.
Right.
So is the waveform measuring something that's happening to the pump?
Right? How would an arterial line look like in a normal patient compared to how it looks like now?
This is occurring in the normal.
So what does an A-limb look like? How's that? He's saying that there's an extra hump in the balloon pump waveform compared to like an arterial line waveform.
Okay.
So what does that extra hump indicate?
When the balloon's up.
I think so. What's the answer?
Is it when the balloon pump is up?
So what's happening is you're getting diastolic augmentation, right? In a
So
normal arterial line, you're not going to see that big diastolic hump, right? You'll see the dicrotic notch. Let's actually look at this. So you can see what, on the left one, you'll see what a normal arterial line looks like, where you don't have any unassisted hemodynamics, right? And so, we can quickly kind of go over this, but you'll see that inflation of the balloon, which is that blue curve. And, you'll see that sharp increase in the aortic pressure when that balloon inflates just after the dicrotic notch of the arterial pressure waveform. And what's happening there is that you're right, at that notch, you're getting the aortic valve closure. But then after that, you're seeing a dramatic increase in the pressure due to that balloon inflating. And that's what's happening is that you're trying to increase your diastolic pressure, which is the whole point of the balloon pump, to increase coronary perfusion. And then after that, you'll start to see that distinct peak at the end of diastole. And then you'll see that rapid deflation of the balloon just before systole. And that creates that negative pressure that reduces the afterload and then, thereby helping the left ventricle inject blood more efficiently. So what you're seeing here is that the systolic pressure is lower than in the unassisted beat due to that reduced afterload, the beat that follows. And so it's really important to kind of be aware of this, like how it would compare, especially if you kind of switch it to 2-to-1, how your pressures from the assisted beat compares to your unassisted beat, because that's how you know it's kind of being effective. It's hard to see that change when your setting is on 2-to-1, but you can really see it on 3-to-1 when you take a picture and you see like what is the actual amount of support the balloon pump is giving. But the whole point of seeing a balloon pump be effective is to get that increase in diastolic pressure. So, I think the image that I would kind of just ingrain in your guys' heads is that first is that left side of the arterial line waveform, which is normal, versus the right side when the balloon inflates, and you get this dramatic increase in diastolic pressure after the aortic valve closes. Does that kind of make sense?
Yeah, that makes sense.
They do not
So-
care about waveforms on your board exam.
Yeah, it's more for like bedside practice. 'Cause I've seen, issues where it's malpositioned or the timing is incorrect, and then you kind of have to realize like what's going on. And initially it was like a lot of just taking these pictures out and doing it. And I think Jared also had a full lecture on that. So this kind of shows the same thing, right? Is it times it to an EKG, so you're seeing like where the Oratelli strip, and you're seeing that at the midpoint of the T wave is when the balloon is triggered to inflate, and then where you want to see it at the peak of the R wave, the peak systole is where you want to see it deflate, and that's appropriate timing. Sweet. Anyone was welcome to go.
Do the sync or sync already?
Sync or
We
swim
did
for
sync or sync
200?
100.
We
Sorry?
200.
200, because we already did 100.
Yep, sync or sync 200.
Oh, yeah.
All right. The asynchrony seen in this image.
Double triggering?
Yeah, man. All right, so double triggering or breath stacking. Do you want to try and explain it?
Essentially, it's where like sometimes you're not giving a big enough tidal volume to the patient, so they're trying to take another breath, so they're just like double stacks.
Or the
Oh, yeah, man.
sensitivity is too high, one of those.
Yeah, absolutely, right? So double triggering, breath stacking, it's, you're seeing basically the way you identified is you see these two ventilator breaths occurring in quick succession without enough time between them to kind of properly exhale. And so this is just another example of that. And so, these two rapid peaks on the pressure curve and the flow curve, the patient's demand for breath exceeds what the ventilator is delivering, right? And so it could be due to inadequate tidal volume or the sensitivity settings. And so the patient is trying to begin another breath before that first one finishes. And then so because the ventilator detects that, it gives that full breath. And now keep in mind, this all can exist on a spectrum with another differential, right? Premature cycling, where the ventilator is ending the breath too soon. And that can also lead to asynchrony. And so problems that you'll have with this is like you'll get volume trauma, worker breathing, a lot of patient discomfort. And when you look at them, they look uncomfortable. And so Awab, since you're up there, any idea on how to fix this? You kind of mentioned one of them, right? Increasing the tidal volume. What else could you do?
Could you like change the I to E ratio?
Yeah, would you increase it or decrease it?
You would increase it so it gives more time for.
Yeah, you want to basically prolong the mechanical breath, right? So it kind of matches the patient setting. And then, it's like the mantra, it's been all year, is to avoid increasing the sedation, right? If you are playing around with these settings and you're not getting the patients way too uncomfortable, fine. You need to buy yourself time, increase the sedation, but that's what we're trying to avoid doing, right? To try to maximize getting them off the ventilator.
You can
It's all
see
John.
on the waveform on the top, you see how the pressure or the volume waveform, pressure waveform, you see how there's a negative inflection? The patient's trying to initiate their breath. So they try to initiate it there. What they probably didn't do is create enough negative flow coming through so that it double triggered, but on the next breath, they were able to do that. That's why they double triggered. But they were trying to double trigger on the breath before that.
Okay, got it.
So you're talking, wait, don't change the.
The very first negative deflection.
Yeah.
You're talking about this little like blip right here.
Yeah, right? No.
Before, at the end of the first breath.
Go up, there. Because like, see how it's positive pressure, right? So anytime you see the waveform go down, it's negative pressure.
Oh, I see.
So the only way for the patient to do that would be for them to try to suck more air in than you're giving them, thus inducing negative pressure. So they tried to double trigger there. They just didn't get enough, they just didn't get enough in to cause it, the vent to trigger it during the breath. Yeah, the dip. I mean, because remember, a vent is a leaf blower. I mean, that's really all it is. It's just a one-way valve that opens and closes depending upon whether you do it by pressure or flow.
Yeah.
So if you're doing positive pressure in and then you have somebody else sucking pressure in, the valve, the vent is stupid. So all it senses is flow and pressure. So if you do enough flow or enough pressure difference, the vent would just recycle the breath, which is why you double trigger.
And this entire section is on your boards.
Jared,
Yeah,
is Jared here?
Yeah.
I'm in Vineland.
In Vineland.
Oh, okay, yeah, so you don't have to do 2 shifts tonight. I'm gonna do the swing.
Thank you, Sebastian.
You got it. You got it.
That's amazing.
That's awesome.
That was amazing.
Vibing vent 100.
He's a same.
Oh.
right. Finding the vent 100. What's the ventilator mode in this image?
One for the same. Let's also pressure, the pressure's about the same. It's not varying either way, so
Always look for it.
look for the. Pressure control.
Beautiful, man. Beautiful. Right. So pressure control ventilation. So how'd you get there?
Just look at the flag.
You want to walk us through how you got there?
Well, initially I was looking to see which one varies, but then we were looking at the one that was flat on the top. Which one was consistent? So the pressure was consistent. The volumes in theory should vary, but they were the same.
Yeah. So obviously you want to, that is a good start. You want to be careful about that approach. And maybe Jared's about to say why.
No, I mean, I hate these questions. But essentially, yeah, I mean, pressure control, if your pressure waveform is ever squared off, it's probably a pressure control mode. If you have differencing in like what pressure it is, then your tidal volumes are the same as how you would identify like PRVC or what's the, yeah, no, APRV is different. PRVC, what's the VC plus. So like if the pressure is capped off, but like and you have varying pressures with the same volume, that would be VC plus or PRVC. And then, but if the pressure's the same and capped off and the volume is the same, they're nuanced. They probably won't ask you that.
Yeah, this is pretty straightforward, because this is a great example. The straightforward pressure control, that is the fixed variable, meaning that you were limiting the pressure, so the variable is going to be then volume.
Yeah.
So same thing here, volume control, your fixed variable is gonna be your volume, therefore the one that is the variable that can change is gonna be your pressure, yeah. So this is like the simplest way to.
In
real life.
Sometimes they'll ask you the dependent variable, like the fixed variable, the dependent variable and the independent variable. The easiest way to remember it is like, compliance is volume, pressure over volume, or volume over pressure. So no matter where you put pressure or volume, one of them has to change, right? Therefore, one is always the dependent variable, and then what ends up getting cycled is flow.
Yeah. So, I mean, exactly what you guys are saying, right? Like there's many ways to kind of approach it. Initially, I approached it the complicated way, which is like looking at the trigger, the limit, the cycle. And I realized that would take me way too long. And when you're trying to assess this at bedside, especially when an attending is, asking you on the spot, it took me way too long to figure it out. But then when you kind of break it down by like the dependent and independent variable, then I think I agree. It becomes very quick to kind of answer these questions for the majority of them. What you have to kind of make sure is that, first figure out, is it like a assist mode or a control mode or spontaneous mode, right? And so you can see that there's not much, on these curves, there's not much spontaneous effort, which kind of Jared alluded to earlier. So you know that it's like an assist or a control mode. And then really figuring out the dependent versus independent, right? So in pressure control, you're setting the pressure and the tidal volume will vary based on compliance. And so that's why you kind of see all those compliance changes, with like the pulmonary edema in ARDS or something is improving. You'll see that, the volume will change unless the pressure is adjusted. Because the pressure you're independently controlling. And then, obviously in pressure control compared to volume control, a little more nuanced stuff is that you're controlling you're using the respiratory rate to adjust like how much time you're spending in inspiration and expiration. And then for volume control, you're setting the tidal volume, right? And so it's that driving pressure that's going to depend, is going to be determined by your airway compliance. And then what you're changing there is that instead of changing the inspiration and expiration time like you do in pressure control, you're changing the flow rate because that's your dependent variable, and that will indirectly adjust your I to E time, right? The thing that I don't like about a lot of these textbooks, is that they'll give this curve, right? Especially like board questions. I mean, look at the volume control waveform, is that it'll give you that square waveform. I don't know many people that still use the square waveform. I mean, I'll do it to kind of, get, to determine if I've adequately inflated the alveoli, if I'm not being able to do driving pressures. But otherwise, it's just a more uncomfortable setting, and it'll look more like the pressure control flow waveform. So just be aware of that, right? Because you get that decelerating ramp that we like to do. And so once again, in the volume control, you can adjust, your PEEP, FiO2 respiratory rate. But because you're directly setting the volume and the respiratory rate, the minute ventilation, I think, compared to pressure control, is more predictable in a sedated or paralyzed patient. I think you got that one right, so go ahead, man.
Pump it up 200.
Pump it up 200. All right, what's being recorded by the red graph in this image?
Oh, great.
Obviously, before you can answer that, you got to figure out, what you're looking at, which I'm sure you know.
What is that? What waveform is that on what machine?
This is the Impella.
Right on, man.
So what is the white line indicating?
The vertical white line.
Yeah, no, the waveform white line.
I guess that would be the patient, like
Is that what the
ventricle.
ventricle?
No, yeah, systole.
It's measuring like the difference between ventricular pressure and aortic pressure. So it's like essentially quote unquote your stroke volume, right? So what is the red line indicating?
I would imagine it's the pump, it's the Impella itself, right? The pressure that it's generating or the stroke volume is generating.
I think it's the measure of your aortic pressure. It's your measure of your aortic pressure.
So aortic pressure, Uday?
Yep, absolutely, man, right? So some textbooks will say
What's the green
don't worry,
line?
I heard Jared talking. So, the textbooks will say technically it's like your LV waveform, but it's really the Impella coming out of the LV, and it's really measuring your aortic pressures at the root of the aorta under normal flow conditions, right? So this is like your automated Impella controller, standard screen by Abiomed. And so that red graph really should say your aortic pressure, and that motor current, the green one, is the green graph. And you kind of already mentioned what's happening in the LV is the white line. All that kind of makes sense?
Does it make
Yeah,
sense?
just give me 1 second.
LV waveform equals red. Because the LV waveform, it has both your inlet valve, inlet sensor, and your outflow sensor. So it can measure the difference between the inlet and the outlet sensor, whereas the red line is only basically your outlet sensor, so it's going to sense your aortic pressure.
Got it.
So if your red line and white line are ever the same line, you're either too far in or too far out.
Got it.
Jared, be careful.
It's going to be
That's a future question.
Sorry, today. Oops.
Predicting the future.
It's good we would have turned around and looked at it for that question too.
You guys good on this? So the reason, sorry, go ahead.
Go ahead, Uday.
I was going to say it's, I think it's, obviously you guys will, as you guys deal with more with patients on the Impella, especially the unstable ones. And I know Jared and Dr. Glassby can talk a lot more about this than I can, but majority of the times, yes, you will be looking at the numbers. But sometimes, in a critically ill situation, because I'm not that smart, I rely on the waveforms to kind of assess what's going on, especially when it's so obvious. You can narrow your differentials down really quickly if you identify certain abnormal patterns, which is why I think it's important to kind of get comfortable with the waveforms. And then the numbers are there to kind of support your diagnosis.
Let's just not pump it up.
All right, let's do pump it up 300.
Bump it up 300. All right, man. What is the problem occurring in this balloon pump waveform? And honestly, I agree that any waveform troubleshooting should be a 500 question.
Yeah.
But when you look at it enough, like 100 times, it gets easier.
It's not.
It's not providing the support at the right time.
So
It's
is
synchronous.
it too early or too late?
It's too late.
So that would be delayed augmentation.
Delayed augmentation.
Yeah, correct, man.
Delayed answer.
Right, so the balloon pump inflation is occurring a bit too late. And so why is that, right? Do you want to try and explain it?
Now you got it, man.
So I guess maybe try and label everything, right? Where is the augmentation occurring? I'll give you a hint to start off all this. Identify the aortic valve closure.
What did you say?
Aortic valve closure, point B.
Right? So identify the dicrotic notch, and then from there you kind of are able to figure out very quickly where the issue is.
So point B is the aortic valve closure.
Mm-hmm.
And then C is where the pump is attempting to, yeah.
And so what would be potential implications of this happening?
Is it migrated?
So maybe like what would be like the physiological consequence of it deflating too late?
Deflating too late. So you'd have like you could basically have like an empty, like almost like a no pressure.
Or you're increasing the workload, correct, and not having appropriate.
Well, so
Increase
look at the
afterload then. Well, no,
So look at the picture.
No, doing higher demand.
In this picture, I have a comparison to a normal balloon pump working, or a balloon pump working normally. And what do you see as a big difference in the diastolic augmentation?
The shadow that you're showing, that would be like increased afterload, right? Which is not what you want.
So that shadow that you're seeing is what you want, right? That is the diastolic augmentation that you're getting in diastole, right? You want to see that high pressure in diastole when a balloon pump is in place because the blood will go backwards and increase coronary perfusion. That's what you want to see. The balloon is inflated during diastole, thereby causing more coronary perfusion. So if it's inflating too late, then you're not going to get the same benefit from the balloon pump, right? You're getting like suboptimal augmentation of your diastolic blood pressure. And so now your coronary perfusion is not going to be as good as it was before. And so you really, to correct this, you just want to adjust the timing of the balloon pump so it inflates the dicrotic notch. Cool.
Pump it up 400.
Bump it up 400. Back to another impeller question. So what is one possible differential for the pathology identified by this waveform?
Something's wrong with the motor current. I don't know what though. Why is it so high? What is it high?
It's not uniformly there.
Yeah.
Cool. If the motor current is having variations.
So I'll give you guys a clue. Look at the motor pump waveform, which is the one in green, and then now analyze the waveform itself, right? There's obviously something wrong compared to what it was before.
Is there clots?
Nope. Jared, I don't think clots would cause this, right? Yeah, I don't think it would cause this.
I don't think you would see it on the motor currency
Yeah.
waveform. If you saw clots,
You would see it on the
you're showing your purge pressure.
Yep.
So what was the motor varying?
Look at your other waveforms.
So what I'm trying to allude to is you see those big green spikes, those negative deflections in the motor waveform?
Yeah.
Mm-hmm.
That's what I'm trying to point to. And so you're getting these sharp decreases causing negative pressure. And so unless anyone has the answer, I'm going to move forward.
Suction events in hypervolume.
Yeah, absolutely, man. I heard it. So, low volume or RV dysfunction causing a suction alarm, right? And so what I'm not showing here is obviously there's a suction alarm going on. And so what you're really seeing is that those sharp negative deflections. So once again, that LV waveform is the red graph. Whoops. This is the wrong image. All right, let me go back to. So, I mean, just kind of, let me see if it goes away.
Go back to the other one. Go back to the initial question.
Yeah.
Yeah, go ahead.
So again, I mean, Nuday's talking about like the negative, like deflection line motor current, but like look at the other waveforms, right? Some waveforms like have like tall peaks, like go in your ventricular flow, and other ones like almost like you would see with like pulse pressure wave variation. So, and then if you look at the ones like here, and the reason why he said diastolic suction alarms is like, this is what he's talking about. He's talking about like diastolic suction alarms. Like you like see like the little waveform come up.
Mhm.
So that's why he's saying like diastolic, because then there's like continuous suction alarms, which are different. You never were getting this like diastolic portion to it, but you almost see like the pulse pressure variation. And like and so it's most likely because of suction alarm, and most suctions are because either malpositioning or.
And really, when I think about suction alarms, especially with an impeller in place, the first thing I'm thinking is hypovolemia. Yes, you could have RV dysfunction, but the other big one is malposition of the impeller, right? It could not be properly advanced all the way in. And so that's why I threw this picture in. It's the correct one is behind this. But this is what it'll look like if you have improper positioning, right? So compared to the one before that you guys were looking at, you see a normal systolic blood pressure, then you see like those you'll see a negative diastolic blood pressure that recovers at the end of diastole. And the sharp negative deflections in the motor current during diastole, it's likely because, if you don't have enough volume, it's kind of like moving around in there. And it's sucking and creating that diastolic pressure to fall even more. And you'll see that number, that LV diastolic blood pressure, that negative number, it'll drop, it'll come back up, it'll drop, it'll come back up. Versus in this scenario where it's malpositioned, you won't see it recover. So that negative diastolic blood pressure will stay negative. It'll be like -30, -40, but it won't come back up like it does if it's due to hypovolemia or RV dysfunction. And you still see the sharp negative deflection. And what the answer to that first one is you give more volume and or consider a right-sided device. And the answer to this one is you advance the impeller more. But not by yourself. Unless you're Jared.
Pump it up 500.
Pump it up 500. All right, what's happening in this balloon pump waveform? So, you've kind of narrowed it down to 4 choices, right? You said that like in the last question, an issue could be delayed inflation, right? So if you kind of break it down, there can really be 4 issues that could be happening with the balloon pump, right? Especially in regards to timing. It could inflate too early, it could inflate too late, or it could deflate too early, or it could deflate too late.
Deflate too late.
Yeah, so, but like, why do you say that?
It's your second waveform. So the timing is correct.
Right,
because
so-
of where you're seeing C.
Because it's inflated at C, and it's supposed to, at D, it should be deflating. You should have a waveform similar to A, but it's deflating
Yeah.
late and causing a drop.
Right, E and G are the same, right?
Right.
E should be lower than G if it correctly offloaded and
Correct.
gave you more support.
Mhm.
So the fact that E and G are the same means it's probably like deflating too early and not giving you enough time to actually decrease afterload.
Okay.
And so the problem with this one is that you are going to get that increase in afterload, right? So, right. So really what you kind of talked about, right, is that that C waveform that you had it's a lot wider than it should be. And that's because the balloon pump is staying open longer. And so that, that assisted increase in end diastolic pressure, it's not that E, like Jared just talked about, E is not lower than G. And then the other thing you're seeing is that upstroke of the assisted systolic blood pressure, has like that short, prolonged rise. And so the reason this is important is because you won't get that afterload reduction. And that may actually like, make the left ventricle work harder because the afterload's higher. And so oxygen consumption will increase. The left ventricle will have more time in that isovolumetric contraction. And that's like, when you're getting most of your oxygen consumption. And so, you're really causing more harm to the patient. Does anyone know what's worse? Just kind of going back to the previous question, early inflation or delayed inflation?
I'd say delayed inflation.
So, if you have delayed inflation, you're just not getting the same diastolic augmentation that you would like, right? You're not getting the same increase in coronary perfusion. Early inflation is almost always an emergency because now you are impeding left ventricular outflow, right? The balloon is inflating when you're in systole. The aortic valve hasn't closed yet, and you're still in systole, and you're like in this heart that is super weak or that came out of a cardiac cath and this reduced EF of like 10%. You're now inflating this balloon with early inflation during systole, and so you're making the heart work way harder, right? And so early inflation is always worse than delayed inflation. Early inflation has to be addressed ASAP. You have delayed inflation.
How would you fix that today?
One thing is you could adjust the timing, or you can just turn the balloon pump off. That's what I would do. I'm not there messing around trying to figure it out, especially since I don't deal with them that much. I'm just turning the balloon pump off.
If they're all, so most of these things are automated now, and you can't even change them if you wanted to.
Yeah.
Like you can try and mess around with it, but they're so fixed to being automated, like you can't really adjust them at all.
Okay.
Yeah.
The only thing you can do is adjust from either triggered by the electric markers, like the ECG markings, where you can have them pressure triggered. So if one is not working and it's inflated too early, it could just be misinterpretation of the electrical activity, so you can change it to pressure. And then it should theoretically give you, it wouldn't go too early because it's pressure triggered.
Yeah. The reason why this one is also clinically important, the delayed inflation, the very common reason for it to be delayed is that if there's a kink in the catheter.
It's like a electrical or pressure. Like there's only, you can't mess it up.
Yeah.
I mean, I'm sure you can find a way, but like theoretically you shouldn't be able to mess it up.
I've seen two cases in Vineland where obviously we decided to be brave and keep the patient in Vineland, and then perfusion just started to get worse. And then when we turned the balloon pump off, because we couldn't figure out how to change the inflation times, the patient's perfusion actually improved. And I'm assuming that in that case, it was probably inflating too early. The delayed inflation can happen because if the catheter is kinked anywhere, there'll be like the helium flow won't be able to leave as easily, and so the balloon won't empty as rapidly, and so you'll get delayed deflation, even though the timing is technically all correct. And so the interventionist came in and then relieved the kink, and then it fixed the issue. Sweet. Let's try and speed up a little bit. If we have a few questions left, that's fine.
Vibing vent 200.
Yeah.
Sorry, which one?
Vibing vent.
Vibing 200. All right, what's the ventilator mode in this image?
Pressure control.
Close. So what do you think about
Oh yeah, it's very minimal.
Joanna said it.
Yeah, it's APRV.
Right on. Yeah, why is that?
It's a very minimal release time.
Yeah, right on, right? So, I mean, I intentionally zoomed in a little bit. So, that way it kind of becomes a little tricky, but right. So you guys, we just had an awesome, amazing lecture by a legend on APRV. So you guys, absolutely correct, right? These are the parameters that we set as a quick review, your P high, P low, T high, T low. And, the important part here is that you are trying to minimize your T low time to maximize recruitment. This is what it would look like zoomed out on an actual ventilator screen. And if you guys are in the habit of doing this, I recommend getting comfortable with this, adjusting the screen settings so that you can see more time. I always change it from 6 seconds to 12 seconds because I want to see more of what's going on in one screen. All right, cool.
Vibing vent 300.
300. All right, what's the ventilator mode in this image? giving you guys a big clue here, which is that second graph, which is your esophageal pressure manometry. I don't know why the board still tests on that, because some centers obviously still do use it. And even if you didn't have the esophageal pressure, you should still be able to figure it out. And Jared alluded to this earlier, which is if you look at the airway pressure waveforms, what you're seeing before the breath is being delivered.
Your pressure waveform isn't square.
Is it VC plus?
Nope.
Line control.
So let me ask you this. Is it a assist mode or is it a spontaneous mode? So sorry, is it a control mode or is it a spontaneous mode?
Spontaneous.
Yeah, and why is that?
Because it looks like they're trying to like
Yeah.
Initiate.
initiate a breath.
Yeah,
And
absolutely
then-
right. I mean, yeah, it could be an assist mode if they're initiating every breath, but really the important part here is that they are initiating every breath and you don't see a standard pressure waveform. So the answer here is pressure support, right? Something we do routinely, but you obviously have to pay attention to it. So this is just pressure support at different amounts of pressure, and so what you're really trying to look at here, if you're trying to utilize the esophageal pressure, is that that decrease in esophageal pressure as airway pressure is increased shows that the patient is initiating these breaths, and that's what's causing that that breath to occur. And so, the whole goal of pressure support is to provide some respiratory support, right? Decrease the amount of work the patient has to do. And so when you're looking at trying to compare pressure support to pressure control, they're both using pressure to assist your breathing, but the waveforms look completely different. So in pressure support, the flow time waveform shows that negative pressure deflection at the start of each breath, basically meaning the patient is triggering the breath, versus pressure control. The pressure time waveforms are consistent, right? We saw that square waveform, and the set inspiratory pressures will be the same every time, and you won't get that negative deflection because the ventilator is really controlling the rate and the timing of the breath. Now, when you compare it to volume control, you guys see that negative deflection, right? So up there you have pressure control, down there you have pressure support. Oops. And so when you're comparing all this to volume control, you also have a set tidal volume, but you won't see the negative deflection. But instead of looking at the pressure negative deflection, you're looking at the flow waveform, and you're trying to see that that inspiration that from the flow curve. You'll see that negative deflection, the flow waveform, which indicates patient effort.
Today it's 4:10. Do you want to keep going or do you want to change it up?
Let's do this. Let's scrap the other ones because I want to get to the case. And let's focus on the final Jeopardy. Let's just end at that. How about that? Is that cool with everyone?
Yeah.
All right, cool. Final Jeopardy.
Wager it all.
YOLO, right?
All right. What is the reason for the patient's bedside monitor appearing like this? So you've got the heart rate at the top, you've got the arterial line in the red, you've got a PA catheter in place. They're alive because their end tidal looks great.
The arterial is the red line.
Yeah.
That's okay, really cool. I thought AB. That's what I was thinking, no, it's not because there's a pulmonary artery pressure at PAP, right? It's not the same, so. It doesn't have like electrical alternates. CP and the atrial pressure should be roughly the same.
The question I have is, why is your arterial line only beating like
That's ABs compared to the
the
electrical
rate of 72?
Yeah.
Yeah.
I'm assuming by what Jared just said, he figured out the answer.
Is it?
No, if it was tamponade, it would just, you'd have equalization, but you still see some A-line stuff.
So why do you still have electrical activity, but not actual beat?
Is this kinked?
No.
He said it's a good king.
Are you saying is the PA catheter kinked?
Yeah.
How would you explain the arterial line?
Mm.
So the only thing that would cause that I can think of is like some LV failure, right? Or something like that. Because the heart's still getting the electrical activity, but it's not like sending the pressure off the A-line sense. So for some reason, the way.
Warmer.
I mean,
Yeah. They're essentially dead for multiple seconds, and then they get like a blip of a blood pressure.
You guys want the answer?
Yeah.
for the entire stomach.
Yeah.
And then, but the pulse ox is also going with the A-line as opposed to the. ECG shows. Actually, no, it's not. It has an extra beat in there that doesn't have the pressure associated with it. I don't know. I don't know, AJ.
You guys want the answer?
Yeah.
All right, cool.
Very bad.
It is because the patient has an LVAD. They have a heart rate 3. This is an A-line in a patient with an LVAD. You guys want to try and figure out why that would be?
So you just continuous flow. But why would it all of a sudden generate a single beat, Uday?
Yeah. Oh.
So there's still some innate activity, and then depending on, so it's the heart is so weak that they're not generating any pressure, but at some point they're still able to generate some pulse, which is why when you have some innate activity, you will still be able to sometimes detect a pulse in the patient, but it's not going to be strong enough to detect in every catheter that you have in place. That was my understanding. I don't know if that's the right explanation, but
Yeah,
I've looked at this image for a while.
Yeah.
Just normally, well, whoever did this also probably didn't rescale their A-line too. Because even with people who have like almost no ejection underneath with like a 5.5 in, like you still see some sort of like beat to beat variation on your A-line.
Right, that was misleading.
Yeah.
It's very.
I'm gonna kick you.
So LVAD.
I confirmed in the paper where I got this image from.
Yeah.
Sorry?
I said it's an LVAD with a maladjusted A-line scale.
Potentially. So, I mean, the paper was saying it was properly positioned, but the explanation, I can send you the explanation, but basically what they were saying was like, the numbers make sense because you're not going to see a big pulse pressure. You're going to see a small pressure in patients with LVADs. But you will what's it called? Randomly see these like big arterial spikes. And that's basically the heart pump working against the LVAD.
Okay.
The important thing here is that don't do CPR on this patient just because all their, lines are flat. And, the nurse is going to be like, oh, wait, do they have a pulse? And then they don't because they're not able to immediately detect it. And obviously don't want to start CPR on this patient. Solid job, guys. Hope you guys had fun. Do you guys want to start right away or take a few minute break?
I need 2 minutes.